Welcome back, everyone. Today, we are diving into the most mobile and, frankly, the most dramatic joint in the human body, the shoulder. We're specifically talking about shoulder dislocations. And let's be honest, in the ER, this is the bread and butter of orthopedics. It's like a golf ball falling off a tee, isn't it?
Exactly, Dr. Khan. But for our students listening, let's be academically precise. We are discussing the glenohumeral joint. While it is incredibly mobile, that mobility comes at the cost of stability. High yield point right off the bat, anterior dislocations are the most common, accounting for over 95% of cases. And specifically, the subcoracoid position is where that humeral head usually ends up.
Subcoracoid, meaning it tucked itself right under that little crow's beak of the scapula. I love the analogy of a crowbar for this mechanism. Imagine the arm is abducted and externally rotated, like you're about to throw a baseball, and then an external force hits it. The acromion process acts as a fulcrum, literally prying the humeral head out of its shallow socket. Why does this matter clinically? Because if you understand the lever, you understand why it breaks.
And the anatomy of the socket is crucial for the boards. Remember, the glenoid cavity is shallow. It's deepened slightly by the fibrocartilaginous glenoid labrum, but the real weakness is the joint capsule itself. Inferiorly, the capsule is loose and poorly supported by muscles. That's our Achilles heel of the shoulder.
It's like a baggy sleeve. When that head slips out inferiorly and then gets pulled forward and up under the coracoid process, the patient's shoulder looks squared off. Dr. Sarah, how do the examiners describe that look? It's very specific.
They will call it a loss of the normal rounded curvature of the shoulder. Clinically, the greater tuberosity of the humerus isn't there to push the deltoid muscle out anymore. It's moved medially. In our case study of the 64-year-old woman who fell, she even had a slight swelling below her clavicle. That was the humeral head itself sitting in its new, wrong home.
And she was holding her arm in a very specific way, flexed elbow, supported by the other hand. It's the universal sign for my shoulder is out. But here is where we get into the high-stakes part. When you are the doctor of choice in that trauma bay, you aren't just looking at the bone. You're looking at the neighbors, the nerves.
Precisely. The axillary nerve is the classic board favorite for shoulder dislocations. It wraps right around the surgical neck of the humerus. If that head displaces, it can stretch or tear that nerve. Students, you must check for the regimental badge sign, sensory loss over the lower part of the deltoid muscle.
But wait, our patient had way more than just deltoid numbness. She had sensory deficits all the way down to her thumb and the back of her arm. That's the radial nerve getting invited to the disaster party. Why does this matter clinically? Because a subcoracoid dislocation isn't just a pop-it-back-in situation if there's extensive neurovascular compromise.
To explain that, we have to look at the brachial plexus. The cords of the plexus sit right in the axilla, tucked behind the pectoralis minor. When the humeral head is displaced downward and medially, it can compress both the axillary nerve and the radial nerve, which both arise from the posterior cord. That explains her massive sensory loss on the posterior forearm and the lateral 3.5 fingers.
It's a traffic jam in the axilla. And let's talk about why the bone stays stuck there. It's not just the trauma, it's the muscles. The subscapularis and the pectoralis major are like two strong rubber bands pulling that humerus medially. They are actually working against you when you try to reduce the dislocation.
That's a great clinical pearl. The pull of the pectoralis major is why the humerus doesn't just hang out, it gets tucked in tight. Now, for the exam, they might ask about the rotator cuff. Dr. Khan, why is the cuff so involved in these injuries?
Think of the rotator cuff as the dynamic stabilizers, SITS, supraspinatus, infraspinatus, teres minor, and subscapularis. They are fused to the joint capsule. When the shoulder goes, the cuff often goes with it. Especially in older patients like our 64-year-old lady, you have to worry about a greater tuberosity avulsion fracture. The supraspinatus pulls so hard it takes a piece of bone with it.
And if that fragment stays displaced posteriorly, you can't just pop it back in. That requires surgery. Students, remember, axillary nerve equals deltoid teres minor equals C5, C6 roots. If they ask about the most commonly injured rotator cuff muscle, it's always supraspinatus due to its position under the acromion.
So, to wrap this up, check the pulse, check the regimental badge for the axillary nerve, and check the pincer action of the hand. If you see a squared-off shoulder, think subcoracoid. Dr. Sarah, give us the high-yield summary.
Here is your takeaway. Anterior subcoracoid dislocation is the most common large joint dislocation. It presents with a loss of shoulder roundness, medial displacement of the humeral head due to pectoralis major pull, and is most frequently complicated by axillary nerve damage. Always verify the neurovascular status of the radial nerve and axillary artery before and after reduction.
Brilliant. Keep those shoulders in their sockets, everyone. We'll see you next time.